is part 2 of the effective risk management strategies in outpatient methadone treatment training. And I'll now turn this over to Dr. Trusandra Taylor, the speaker for this topic. Okay, Dr. Taylor, we can see your screen now. Dr. Taylor?
Maybe her audio's down. She looks green on the panel.
Yeah. Dr. Taylor, can you speak so we can see if we've got you in here correctly?
Can you hear me?
A little bit louder, please.
Can you hear me?
Yes, perfect. Thank you.
Okay. Well, I had you on speaker. I guess it's not active. Let me try again. Can you hear me? Can't hear me?
I think it was pretty mild. I can adjust my audio, but I don't know if all the attendees.
All right. Well, all right. I'll avoid the speaker and hold the handset.
Okay. Thank you.
Okay. How can I get rid of this little panel here? Can you see the panel with the bar?
In the upper left-hand corner of the panel, you see that little orange square with the arrow?
Yeah.
On it, click that arrow, and it will reduce the whole panel.
Okay, but I can't get rid of it.
Well, you'll get rid of the you'll get rid of everything except those little icons on the left. It'll just be very, very tiny.
All right. All right. Okay. Well, we'll begin.
Or just push it over, and you can narrow it too.
Yeah, I'd like to begin with just a brief recap of modules 1 through 3. Module 1, oh, I hit the down arrow. Thought this was going to work. Here we go. Module 1 was an overview of what we're talking about, risk management for OTPs. We started out looking at what I call the big picture, what's going on out there, and further looking at a closer look of the issues related to OTPs and risk management related to opioid medications. We started out by looking at the global consumption of opioids. I pointed out that there's a disparity in terms of developed and underdeveloped countries. It's estimated that the consumption by developed countries is about 80%, and the developed countries, including the United States, occupy about 6% of the world's population. Within the U.S., that consumption is about 4.6%. That's the estimate. So you can see there's a disparity in terms of the global consumption of opioid medications. We next looked at what we call the problem of prescription drug abuse, the epidemic that's presently, in the United States. There's been a dramatic increase in issues related to prescription medications misuse, and we discussed some of the comprehensive plans by the federal agencies, ONDCP, SAMHSA, CSET, NIDA, the FDA, and the DEA. There's a concerted effort to address this problem. We focused on the issue of trends involving overdose deaths, involving specific categories of medications. We next talked about the issue of methadone-associated mortality and addressed the conundrum that much of the literature has established that many of the, or most of the methadone-associated deaths are related to issues involving pain management treatment, and the focus, however, is on both OTPs and pain management. And I pointed out that there's been extensive review and that the mortality, the last assessment meeting was in 2010 in Washington, and the report, I believe, has been published. I also emphasized the issue that part of what was recommended in that reassessment meeting is that opioid treatment programs should participate in reporting of mortality to SAMHSA and their federal or their state agencies. And SAMHSA has a voluntary initiative whereby they want all OTPs to report any deaths of patients who are in treatment regardless of the cause. And when we focus on that, we'll be able to have better data in the future. And lastly, in terms of the first module, we discussed the important issue of liability insurance for OTPs. We looked at trends in terms of what these issues are, and that there's concern in terms of the risks that are involved. Let me see here. It's not trying to get the computer working. Okay. Now, in Module 2, we discussed managing risk. We talked about some traditional and basic definitions of risk management, particularly related to healthcare settings. We talked about the process of identification, analysis, treatment control, and specifically we discussed in some detail some what we call methods and techniques that are commonly involved in risk management: the acceptance of risk, the avoidance, prevention, reduction, exposure, segregation, and contractual transfer. And lastly, we talked about the process of risk management in terms of a cycle, a continuous process. It's just not a one-stop or one-step involvement, and that it's a comprehensive effort required by all staff involved in opioid treatment and an opioid treatment program. And lastly, in Module 3, we discussed the relationship between risk and practice, focusing here on what we call the ideal standard of care, involving admission, competent staff, good clinical judgment. And then we talked about what are these core liability risks, related to opioid treatment programs: failure to document, to communicate what the risks are involved, and to consider what we call a foreseeable problem and taking reasonable action. Assessment, we briefly discussed assessment for impairment, and we're going to spend quite a bit of time today talking about that. We talked about the issue of risk at admission, and an effective risk management strategy is to implement what we call informed consent, and it should be phased in terms of not only at admission but throughout the continuous process of treatment, that you should have evidence that you are informing patients and getting their consent for adherence with treatment. Also, we discussed the issue of integrating the family into the patient's treatment and educating the family about risk involved and overdose prevention. We lastly touched on impairment, and we identified some high-risk areas for impairment. Okay, that ends the recap. If there are any questions related to that, I'd be willing to take them now before we move on to our Module 4.
We can unmute people, and they could try to speak through their phone, and we can see if there's any background noise or anything.
Yeah. You want to do that?
I did. So people, everybody's unmuted that I can see on the panel that has a telephone connection. If somebody wants to try, you can use the little yellow hand icon to raise your hand, and we'll call on you so we're not talking over each other.
Well, I guess there are no questions.
No thoughts or feedback?
Okay.
It's all right. We caught them off guard. You can think about it. And
yeah, okay.
in time, Chris, we can unmute people and try it and see how that goes.
Okay, let's move on to Module 4. Well, first of all, let me share what we're going to talk about this afternoon in the 2 hours that we have. Module 4 will deal with impairment, and Module 5 will be discussion about take-home medication. And Module 6, I'm going to present some case studies, 3 case studies that outline some of the principles that we've discussed today and in the previous training. Okay, our agenda for the first module, Module 4, we're going to discuss in detail what we mean by impairment. It's essential as a trainer to understand the definition and a general understanding, and to also look at the legal perspective and the medical clinical perspective in terms of impairment. It's important to understand how to assess for impairment, particularly in the OTP setting. What are the essentials for that? It's important to understand high-risk situations, and then we will talk about specific risk management strategies relevant to the issue of assessing and addressing impairment. I'd like to clarify some terminology and definitions. Some of these are used sometimes interchangeably. There's a distinction, and we need to have an understanding of impairment, intoxication, competence, informed consent, and disability. Now, from the legal perspective in terms of the definition, impairment is defined as a person's faculties are reduced such that their ability to see, hear, walk, talk, judge distances is below what is normally expected. And generally we think of this in terms of the use of drug and alcohol issues, but it can also be contributed to a medical disorder or a mental illness. It's important to note that if a person's alcohol level is lower than the legal intoxication level, they can still be what we call convicted of having impairment based on, their ability. Now, from this is rather global. From the medical perspective, impairment is defined as an abnormality of partial or complete loss of or loss of function of a bodily part, organ, or system. So you can see it's very expansive, but nonetheless, when you think of the medical definition, that's the boundary in terms of what we're talking about. Now, intoxication means a pathologic state that can be induced by an exogenous or an endogenous toxic substance, a state in which a person's normal capacity to act is inhibited, typically by drugs and alcohol. That's typically what we mean when we say someone is intoxicated. But an intoxicated person is considered incapable of acting in an ordinary, what we call prudent and cautious manner under similar circumstances. And this is what allows the law in some cases to allow patients to use this as a defense in terms of, well, they were intoxicated, so where their judgment was impaired. Now, we all recognize the common intoxicants with substance use disorders. We're not talking about a medical condition or some state by which a toxic substance can be, achieved in terms of the patient's body or system. We're talking about alcohol, sedative, hypnotics, or anxiolytic drugs such as benzodiazepines and other drugs that are used for sleep aiding and dealing with anxiety, typically controlled substances. And of course, we're talking about opioids, both the natural and the synthetic opioids, prescription drugs. Stimulants, you can be intoxicated from things such as cocaine, amphetamine. For the most part, these are the most common stimulants. And lastly, hallucinogens, such as phencyclidine, is the most, and marijuana. If a person is using a lot of marijuana, you can have an intoxication related to that. Now, there's one area that I didn't include here, and it's not necessarily in terms of substance use. It's a medication that can be considered in terms of intoxication, and this is muscle relaxants. In particular, there's one that has recently been in the press in terms of a dramatic increase in emergency room presentations related to adverse reactions and an overdose related to what I'm talking about is it's commonly the carisoprodol is a drug commonly known as soma. And there have been reports of intoxication in combination of other drugs such as opioids and methadone and benzodiazepines that is of note. So I'm pointing this out in terms of another category of medications that can be involved with intoxication. Let's look at specific criteria. It's important to understand and recognize the DMS-4 criteria for drugs such as alcohol. There should be documented use of alcohol and a clinically significant maladaptive behavior and psychological changes either during or shortly after, as manifested by slurred speech, incoordination, unsteady gait, nystagmus, which is abnormal eye movements, and we'll talk about that, impairment in your attention or memory, and in your depression in the mental status in terms of the stupor or comatose state. And also as a requirement, the condition is not due to a general medical condition and is not accountable or accounted for by another mental disorder. So you can see these are the DMS-4 diagnostic criteria for intoxication that is determined to be due to alcohol. And we'll talk about this later in terms of evaluation of patients and documentations of these particular findings. Looking at sedative hypnotics, as I pointed out, drugs such as benzodiazepines that are used for sedation, relieving of anxiety, and sleep relief. Again, recent use of such a drug, and there's maladaptive behavior and psychological changes shortly after or during the use of these drugs. And again, you have the common scenario of one or more of these findings of speech, slurring of the speech, incoordination, unsteady gait. You can have nystagmus, impairment of attention or memory, stupor or coma. And again, it cannot be due to a medical disorder or another mental disorder. So you can see there it can be, it's overlap here, particularly with sedative hypnotics and alcohol. They can look the same. Now, opioid is a little different in terms of, again, the DMS-4 criteria for intoxication related to an opioid, heroin, or any prescription opioid medication, recent use of the opioid, maladaptive behavior and psychological changes during or shortly after the use. But the findings are a little different here. Here you would have what we call pupillary constriction, meaning the pupils are very narrow or small. We commonly use the term of pinpoint. And note here says that dilation is, if it's noted, if the patient is anoxic or without, oxygen in a severe overdose, they're not breathing. And then the additional signs that you would look as obviously depression of their CNS, drowsiness or a comatose state, slurred speech, an impairment in attention or memory. And again, you ruled out that there is not a general medical problem or another mental disorder which is accountable for this state. Just want to emphasize again here, in medicine we call in an opioid overdose, particularly involving heroin and other drugs in that class, you have the classic, what we call triad in terms of the CNS, comatose state or marked sedation. Respiratory depression is very low, and the pupils are pinpoint. We call this the classic triad of an overdose. Let's look specifically at what would you see or observe or document in terms of if you were documenting intoxication related to a stimulant such as cocaine or amphetamine. Again, there has to be recent use of a stimulant such as cocaine or amphetamine. You'd see the maladaptive behavioral changes and psychological changes, but note the difference here. Euphoria, affect blunting, changes in sociability, hypervigilance, interpersonal sensitivity, anxiety, tension, or anger, stereotype behaviors, impaired judgment, and so forth. It's characteristic if someone is very high or intoxicated related to cocaine or amphetamine typically. And in terms of additional signs, you can see the criteria indicates that there should be 2 or more of the following. Tachycardia, which is an increase in the heart rate, or it can be a decrease in the heart rate. The pupils here are dilated characteristically. The blood pressure can be up or down. The patient can have perspiration or chills. You might see nausea or vomiting. And characteristically, the patient, if you've seen them over a period of time, there's evidence of weight loss. They have either psychomotor, what we call retardation, or slowing down, or they're very agitated. And there's complaints of muscle weakness, and there's respiratory depression, and so forth. And again, the criteria indicate that this condition or state is not due to a general medical condition or another mental disorder. Again, just to drive home, we're talking here about the adrenergic or sympathetic nervous system involvement that you see, the dilated pupils, the profuse sweating, the elevation typically, usually, of the blood pressure and heart rate, and they may even have an elevation of their temperature. And characteristically, some patients are, you'll note that they have what they call bruxism or teeth grinding. Now, lastly, looking at the category of hallucinogens, phencyclidine, marijuana, recent use, you have this pattern of what we call maladaptive behavioral or psychological changes characterized by marked anxiety, depression, ideas of reference, paranoid ideation is very characteristic, impaired judgment, impaired social and occupational function. And here the specific criteria, again, you can have someone, you can see overlap. You have the pupils are characteristically dilated as opposed to being constricted, increase in the heart rate, tachycardia, very rapid, sweating, diaphoresis, palpitations, feeling the sensation of their heartbeat, blurring of their vision, tremors, and incoordination. And lastly, again, ruling out a medical or mental disorder. Now, as I said, it's important to understand the terminology. Now, competence is often used in this sense of impairment. We need to understand from the forensic perspective what is intended to be meant by competence. Well, firstly, it's the legal recognition of an individual's ability to perform a task. Now, this concept is not accepted globally, but this is the general consensus. And what we're talking about here is their competence for a specific category in terms of their assistance with legal counsel in preparing their defense related to a specific complaint, or manage their financial affairs, or in relevant to our situation, their ability to give informed consent for medical matters. So again, a competent patient has to be competent in order for them to give what we call consent. Informed consent, again, from a forensic or legal perspective, is what we're talking about, the patient being able to give authorization, and they're not forced or under any influence to give to make their decision about, what they understand in terms of what is happening. as I point out, an incompetent patient is not able to give informed consent. Then you might think about patients when they come for admission and they're in distress, and you have to make a decision. Is the patient competent in terms of being able to give informed consent regarding their acceptance to treatment, their understanding, the risks, and they actually have to sign various consents to agree to treatment. So you need to make sure that the patient is not under duress, the patient is capable of giving their consent. In terms of the definition, or from a forensic standpoint of understanding in relationship to this issue of impairment, disability is defined as in medical practice, what we're talking about is the patient able to work or perform certain actions in terms of being certified related to like Social Security or insurance. So often, this term of disability is applied in the sense of impairment. We're talking about a specific physical or mental impairment that would substantially limit what the patient is able to do, and that there should be a record of such an impairment. Now, so we have some understanding of what we are speaking about in terms of the idea from the legal and the medical perspective of impairment, intoxication, competence, informed consent, and disability. So in terms of assessing impairment from a medical or clinical perspective, let's think of some common triggers for assessment. Now, again, our focus here is in an opioid treatment program. You should have what we call an index of suspicion in terms of, is the patient impaired? Usually there is a history of either recent or prior episodes, but there may not be. And we'll get into, presentations of new patients for the first time. But again, you should start out in terms of having a high index of suspicion for certain circumstances if there's a history or prior episodes. It's important to recognize that the induction period, and we define that as the period when the patient is starting methadone. And induction is generally within the first 2, possibly as long as 4 weeks for most patients, until their body becomes adjusted or they establish and you witness tolerance to the medication. So a trigger for assessment is during the induction period. That patients should be carefully evaluated to assure that they're not impaired. Patients often use other substances such as alcohol, and if there's any detection on their breath or if they're drug screened, some laboratories will screen also for alcohol in the urine as an indicator. And that's a good area to keep in mind in terms of assessment. And also, many programs use a breathalyzer, or they get a blood alcohol reading on the spot. So again, that's a means of readily detecting alcohol. Now, other patients in the clinic sometimes will report other patients, and you need to take this with a grain of salt, but nonetheless, that can be a trigger. Comments from other patients and observation. Staff observation of patients, and here we're talking about all staff, not just the medical or clinical staff. Oftentimes the support staff, the person who checks the patient in at the front desk or the receptionist will note behaviors that should be followed up on in terms of being possibly a trigger that the patient needs to be assessed for impairment. And also, any aberrant or unusual behavior that is noted by the patient should be a trigger. It's also to consider other etiologies, as I pointed out. Sometimes medical conditions or illness. Patients have a variety of medical problems. You know, and the list can go on and on in terms of medical disorders that can simulate or give you the impression that the patient is impaired due to substance use when it's really a medical disorder. There are a variety of drug interactions involving medications that can create conditions that create toxicities in terms of drug synergistic reactions between medications involving methadone, whereby the plasma level is greatly increased, or the effect of the other medication has an adverse effect upon the patient, and this can be the cause of impairment. And of course, illicit substance use, the combination of other drugs such as alcohol, cocaine, benzodiazepines, and so forth in combination can be contributed. So we move now to how do you adequately and effectively assess for impairment? Well, it starts at the very beginning with observation. You observe the patient, their appearance, and overall you get an impression, and you make a decision on how you want to proceed. You need to have a conversation with the patient that is respectful. You need to advise them why you're concerned and what the reason is for the evaluation, and this needs to be done in a private setting and in a confidential manner. To give you an example, if a patient presents at the clinic and any of these triggers are noted, the patient needs to be taken aside, and the need to discuss this in a private manner and not confront the patient in front of other staff or other patients in the waiting room and so forth. A simple diagnostic assessment can be done by doing a blood alcohol level with a breathalyzer. Sometimes you can use those instant kits for drug testing, where it's like a dipstick. You can do those because sometimes clinics use those for quick assessment. You can't use that in terms of documentation upon admission, but they can be used in circumstances where you want more or less like a rapid assessment to see if a patient has recent use or evidence of using benzodiazepines. Some of the kits are multi-drug and some are specific for certain substances. So simple diagnostic testing can be helpful in terms of you getting information. Specific testing involves a full-fledged, what we call mental status exam, and we'll talk about that, and a neurological exam, and there's also an instrument or tool called the Montreal Cognitive Assessment, and it's like an examination that you can do. It takes about, I believe, 10 minutes to do that. It's about a 30-point question test that you do. So these are specific instruments that you can use to assess a patient for impairment. Something that's very simple is looking at the patient's handwriting and their signature. In some programs, patients are required to sign for their day of service, and if you can look at the service log and compare it to previous signatures, it's a very simple test where you can simply ask the patient when you're evaluating them privately, write down your name and address for me and just observe. And believe me, that's very telling sometimes when a patient is really impaired, and you can make a decision right there. In terms of assessment, the treatment plan should be reviewed because maybe this patient is not getting the right level of service and needs to have an increase or a change in the level of care. So the treatment plan should be reviewed in terms of assessing for impairment. Let's look at in more detail what areas need to be assessed. I pointed out indicators of intoxication or impairment generally involve what we call the central nervous system, which is responsible for the body's overall functioning, and also the autonomic nervous system. So you're really evaluating the central and autonomic nervous system. If you're not familiar with what we call the mental status exam. These are the major areas, and there are many versions of it that are standard in terms of textbooks of psychiatry and medicine that can be adapted in terms of designing a screen. But the main areas include your documenting the patient's appearance, how do they appear, their manner of dress, their overall presence, their attitude to the examiner. Are they hostile? And do they have an understanding of, what is happening? Their mood, their affect, their speech, their thought process, their content, their insight, judgment, and impulsivity and reliability. This is very standard, and like I said, there are many versions of forms that have mental status exams and can be done when you need to do a full-fledged mental status exam. Let's look at specific areas because you may not have to do the full exam. You can start out in a certain area and you have a decision automatically based on, the patient's presentation. Here we're talking about their appearance and attitude, the physical and mental aspects. Many times it's overt and obvious, but there are times when it's very subtle. And you get an understanding of this after having experience with patients over a course of time. You can see that there's a subtle, it's not exactly, it doesn't hit you in the face, so to speak, but you can see that there's a problem and it's subtle. And like I said, with experience, you'll get to have a better feel for that. Mood and affect are looked at in terms of the patient just normal or euthymic, or are they, dysthymic in terms of, being down or very abnormal, or are they manic? Are they angry, irritable, hostile, as I pointed out? Or they can be calm, anxious, or panicky, or sometimes they can be elated, particularly if they have bipolar disorder. Their speech is very characteristic, and that's what I said about in terms of the subtle nature. If you've seen patients over a period of time, you'll get to recognize in some patients what many of us have observed is this subtle change in their speech. Characters you look to see, is it spontaneous, is it slow and deliberate, or is it slurring? And sometimes you can see, particularly with patients who are on sedative hypnotic medication or anxiolytics, in particular benzodiazepines, there is this phenomena that you can see a change in their speech that's, not necessarily slow, but it is deliberate in many of the words that they use, and there's a differentiation that, that it's slightly slurred. There are patients at times who are impaired, who are speaking very rapidly, and their speech at times can be illogical in terms of you don't really understand what they're saying, and it doesn't make sense. Now, this is talking about the eyes and how you assess for nystagmus. Nystagmus can be horizontal or vertical, and this is an abnormal movement of the eyes. And I realize that most of the participants in the audience are not physicians or medical personnel, but we wouldn't expect, such individuals to do a very specific examination of the eyes, but it's something you should have knowledge of in terms of this issue of nystagmus, meaning a horizontal abnormal movement of the eyes that maybe characteristically indicate that the patient is under the influence of a sedative or alcohol or barbiturate, benzodiazepines. Vertical mean up and down nystagmus, which is unusual. Again, it's more characteristic of patients under the influence of phencyclidine, PCP, or ketamine, or a very high dose of an opiate, morphine. So, but more characteristically, what we look for with the patients in terms of their eyes, in terms of intoxication, is are the pupils constricted or pinpoint? You can take a flashlight or a pen light and shine it in the patient's eyes and see how they react. And if they're pinpoint, that indicates a certain category of drugs. If they're dilated, again, it's different. So the main thing is you look for evidence of this abnormal eye movement, horizontal or vertical, very rapid movement, or at times it can be rapid. Or you look to see more commonly what the pupil size is and how they react to light. The psychomotor status or state here again, is it retarded in terms of slowness, unconscious, and it can be from a full level of unconscious to stuporous, conscious but drowsy, but slightly slow. They move very slow and their speech is slow. That's what this is what we mean by psychomotor retardation. Or are they very alert, very hyper in terms of hyperactivity and combative? You can't keep them still. So again, the psychomotor status is either sedated or retarded or agitated. This is a very practical means of testing someone who is, you can think, or you're trying to evaluate if they're impaired, is simple things such as the walk and turn test, one leg stand, Romberg. This is a specific medical test, and I wouldn't expect you to necessarily know that, but again, finger to nose, and you've seen patients do that. Heel to toe walking, the straight line or sobriety test. This is very simple to do with a patient in a private setting. Just simply said, I want you to start at the back of the room and, walk heel to toe in a straight line. And you'll see that many times a patient who is impaired simply cannot do this, such as, this test as well. So this is very practical, and you don't have to be a physician or a medical person to evaluate. Orientation involves the following spheres: time, place, person, situation. Usually in an opioid treatment program, most patients are oriented to, they know where they are, who they are in the situation, but they can be off in terms of time, in terms of their memory, and we'll go into that a little more. Space we're talking about here is an opportunity to evaluate their handwriting, or they can do what they call the bender to sculpt, to draw a square or a triangle and just observe. Memory, again, is very practical. Most patients will have problems with immediate and recent memory, and remote memory usually intact. And if you ask them about dates and so forth, they often are confused or they just can't remember, and that's sometimes an indication that they're impaired. Vital signs can be helpful at times, but for the most part, vital signs aren't what I call diagnostic in the sense. Yes, you can have an increase in their temperature if they're using stimulants and so forth, and their pulse can be either up or down. Respirations is important in terms of recognition with the use of opioids, because depressed respirations, to the point that they're less than what would be considered the normal range of 12 to 16, can be indicative of, a serious or potential overdose and death. So the patient's respirations are markedly depressed, less than 12, and they really are measured correctly. You should note that significantly. And the blood pressure can be up. The systolic can be up, and as well as the diastolic blood pressure. Now let's focus on impairment in terms of what we mean by risk management and advising our patients and addressing it and following our patients. We need to recognize that an impaired patient has the potential to not only cause harm to themselves but to others, and this is what we talk about in terms of liability. When patients are operating what we call heavy equipment or machinery, particularly when they're driving automobiles, motorcycles, or any kind of motor vehicle accident. And recent trends in terms of insurance claims are noting that there is an increase in what we call wrongful deaths due to an impaired patient in an opioid treatment program, in a methadone program, who was driving. So this is a serious area in terms of recognition. And any suspicion should trigger what we call preemptive actions in terms of our risk management strategies. I think we pointed out previously the high-risk situations and OPPs during the induction process. Again, when the patient is first admitted to treatment, there are a number of issues, getting to know the patient, getting an accurate history. Many patients, well, I shouldn't say many, but some patients don't engage adequately in treatment. Their attendance during that process is irregular. They may not come every day for their dose, and it's very difficult to titrate their dose safely and get them to a point where, they're not experiencing withdrawal and the medication is effective. That induction process we generally allow within the first 2 to 4 weeks, and the most significant period of risk is in that first 2 weeks. Statistically, studies show that patients have the highest risk of overdose and death during that period. We also identified drug-drug interactions involving methadone, either illicit drugs or prescribed medications, and they're listed here. And I pointed out, lastly, the issue of soma being more and more recognized, carisoprodol. There was a recent, I think, dear colleague letter or an advisory that is listed on SAMHSA's website, and you can get that information about noting the problems related to carisoprodol. When there's prescribed medication and the patient is taking this, you must deal with this issue of the impairment. In terms of what we're saying here is that the patient may have a prescription from a prescribing primary care doctor or a physician outside of the clinic, psychiatrist, and the patient considers this legitimate, but if there's evidence that their impairment is due to their prescribed medication in combination with methadone, you must deal with this first in terms of addressing medicating the patient, decreasing their dose, or taking some action. In terms of the longer-term plan, or subsequently, the patient's prescribing physician needs to be contacted, and the patient needs to give consent to allow that process so that you can communicate what the problems and the issues are. So again, you must deal with the impairment first in terms of addressing it and taking preemptive action, and then a long-term, or not necessarily long-term, but a follow-up in terms of the longer-term issue of addressing, notifying the prescribing doctor and dealing with those issues. An effective risk management strategy in an opioid treatment program involves clearly establishing what we call a climate of impairment awareness. And this is a total opioid treatment program community effort. It involves educating the patients and having policies and procedures for which they are informed of. But again, the emphasis here is that it involves the entire program and involving the patients and with documented policies and procedures. Here, again, we're saying the same thing in terms of identifying impaired patients. It's a total effort. It involves, in many cases, starting out with your support staff, the security staff, if your program has that, if you have receptionists or people who check your patients in, or if they have to see somebody in billing or service management. They're important in terms of identifying these patients. Obviously, your medical and nursing staff, the clinical staff, and we need to not forget about the patient's family in educating them, and we also need to, acknowledge other patients in the program who have concerns or will state any observations they have about other patients. So it's a total effort in terms of the program. Now, what do we mean by reasonable inquiries? Well, they should be regular and directed to all patients. You should have a process at admission, and it should be continuous. You should have protocols involved, that specifically address what to do when a patient is observed. So it should be regular. And obviously, you need to have emphasis upon new patients, because many patients, when they're new, are still using other substances, and some patients don't engage readily. They don't adhere. They don't come as they should for treatment. So again, these are your most risk patients, or highest risk patients. So new patients and patients who are continuing to use other substances. In Module 2, we talked about managing risk, and we talked about some specific strategies and methods, and what we call techniques, related to some identified methodologies: risk acceptance, avoidance, prevention, reduction, exposure segregation, and contractual transfer. Just to review briefly what we mean by risk acceptance, you know, you're in the treatment business and you have to accept that there are certain risks involved in terms of patients, and you can't avoid that altogether. Patients have, you know, certain behaviors, and you expect some patients to have difficulty and some patients to be non-adherent, but you're confident in your program and your staff and their competence and their ability to recognize and to address this. So you have to accept some risk in terms of this issue of impairment. In terms of exposure avoidance, here you're talking about eliminating the risk altogether. Well, you know, what we're addressing here is, as an example, if you want to focus in terms of this, an example would be not to medicate a patient until they're seen by, say, a physician or a medical staff. Here you're trying to eliminate your risks altogether. So the point of these different methods and techniques is that they're not necessarily mutually exclusive, and there's overlap, and it doesn't mean that you have to involve or use all of them. It's just some examples of how risk can be you know, addressed in terms of a method or a technique. Let's look at loss prevention. Here the emphasis is upon early detection, incident analysis, observation. The focus is to pinpoint loss in terms of prevention areas. An example of this would be using informed consents for clinic policies and procedures to address impairment. If you look at loss reduction, your measures here are to control any adverse events through such as staff education, educating your staff on how to adequately and effectively assess for impairment. Looking at exposure segregation, here you're talking about maybe separating out the problem and looking at intensive control actions or measures. An example of this would be maybe if you develop a specific activity for patients who have problems related to benzodiazepines or alcohol, such as some programs have a benzodiazepine group, or what we call, not necessarily a group, or track, in other words, where they have intense control measures in terms of their treatment that is organized around this issue. And I've seen some programs have similar type activities for patients who have other problems such as cocaine or alcohol. So those are just some examples. In terms of contractual transfer, here the issue is where you're transferring or shifting your risk, avoiding any liability loss by specific insurance policy or contract. And, you know, from our perspective related to this issue, you know, that's impractical. So, you know, you don't necessarily have to have all of these methods or techniques. Just to give you some examples of how activities that you would implement would involve either an overlap or a combination of these particular methods or techniques. Now, let's talk about red flags. And here, I'm just going to summarize some issues of cases where an opioid treatment program knew or should have known. As an example, a red flag patient would drive while impaired. Medicating, knowing the patient would drive impaired, or the evidence was ignored, or the patient had use of benzodiazepines and it was documented that it, in particular it was illicit, that they were using a street source, or they may have used or have a legal prescription. But again, these are red flags that have been documented in cases of litigation against opioid treatment programs, whereby that it was noted through comments and records in terms of the patient's documentation that they knew the patient was impaired, but they let the patient drive or operate a motor vehicle, and they subsequently had an accident, and there was a third party involved. So again, you have the obligation, we'll talk about this, to report this. This is what we mean by evidence ignored. The evidence was there that there was aberrant behavior, but yet there was no documentation of any accident or action that was taken that was reasonable and foreseeable to prevent any kind of liability. Again, in terms of a summary of what we call the legal standard, opioid treatment programs need to take all precautions for reasonable action, ensure that a patient is not impaired prior to dosing, and you need to have policies in place such that you can address this in an appropriate and timely manner. You need to inform the patients of the side effects of the medication, of methadone, etc., and that they need to establish time and tolerance and allow their body to adjust to methadone. You need to prevent patients from driving, and you need to follow and check on your state regulations because it varies from state to state, but most states require that if you really feel a patient is impaired, you should report that patient and take effort to prevent that patient from driving. I know this is controversial, but you, as a physician and as a medical staff person, you have the obligation to enact that. Now, the OTPs have a legal duty to take action once a patient is identified, but this does not necessarily protect you from a claim. So, again, this needs to be followed through. You have a duty to inform the patient through what we call the consent process, and you have a duty to warn if there's this evidence or indication of impairment and that would jeopardize the safety of the public and others. You need to observe whether a patient is impaired and assess and monitor new patients in your program. And you need to investigate if the patient has a problem with multiple drugs or other drugs, cocaine, alcohol, benzodiazepines. You have a duty to delay, defer, or refuse dispensing of methadone. By this I mean if the patient is truly impaired, the patient should not probably receive their methadone for that day. In some cases, programs are very good with this, and in other cases, this is not the case, and the patient is either dosed or, in some cases, the patient is given a partial dose. That needs to be a clinical or medical decision in terms of dosing the patient when they're impaired. And you need to act, if the patient is posing what we call foreseeable risk to others, and report any dangerous situations to the appropriate authorities like the Department of Motor Vehicle or Transportation, so forth, according to what your state is designated as. In terms of decisions, again, you need to make a decision whether this patient is going to be medicated. If you're going to medicate and monitor, say allow the patient or request that the patient remain in a period of observation for some time, and if necessary, if you're going to do that, then you need to make sure that the patient can be transported home safely, and you need to make those kinds of arrangements. in terms of overall strategy, it's important to have what we call a no-tolerance policy for impairment. This means that you are vigilant in addressing it, and patients are aware, and that you have you have procedures in place to address it adequately. There's no tolerance for impairment, and that you act upon it swiftly and appropriately. Patients need to be informed. There needs to be what we call releases of information to allow the clinic staff and the medical staff to collaborate with any outside agencies or prescribing doctors related to their medications or any issues. You need to have privacy for the patient and maintain confidentiality. You need to have some understanding of possible helpful diagnostic instruments and tools for assessment. And your staff need to be trained, and you need to have activities that will help them in improving, their competence in terms of this. Documentation is key. You need to document that action, that the patient was assessed and it was done adequately, and that their treatment plan, if it needs to be revised, it was done appropriately. Just in summary, again, the treatment plan needs to be reviewed and revised, because in some cases patients need a higher level of care or more intensity, and this needs to be stated. You need to have an index of suspicion, and you need to have emphasize safety for all, meaning you have an obligation to protect the public and the patient as well. Okay. So I believe that ends, yes, Module 4. Do we have any questions before we move on to 5, which is take-home medication?
Yes, Dr. Taylor, I do have one. They said you talked about Soma, but do you see the use of Lyrica increased among methadone patients to get the euphoric feelings?
I haven't personally, but I've heard of scattered reports. Lyrica is a rather new medication. Soma is a very old drug that's been on the market for, been used over several years. And the important thing about Soma is that it metabolizes to a very toxic metabolite called meprobamate, and hence the toxicity. But in terms of Lyrica, I have heard of scatter reports, but nothing like I have seen, and not only from my work as a physician, but other physicians have shared their concern about Soma, at least in this part of the country on the East Coast. I don't know about, it varies according to your region.
Right. Yeah, I don't think this, I'm going to unmute everybody right now, and if you have any questions, please. Yes?
Okay. So we're moving to 5 now. Okay. Let me see here.
We're getting a little feedback. I'm going to turn off my speaker here then, and I don't know if it's coming from, if your phone is close to your computer speakers or something, but we'll see if
you're getting feedback? No, it's on the other side of the desk.
Yeah, not right now, so.
Okay.
Yeah, in the future, though, if people want to talk through audio, use the little yellow hand icon, and we can unmute you. That way you're unmuting one person at a time.
Yes, thanks.
Okay, let's move on to Module 5 in the series related to risk management strategies for opioid treatment programs. We're talking about clinical guidelines for liability prevention. Take-home medication is another area that has been recognized. Take-home medication, these are the federal guidelines here that's pointed out. It's important to recognize that the medical director of the program has the ultimate responsibility for decisions regarding ordering or giving or writing for take-home medications. Regardless of how the program is structured, the buck really stops with the medical director. The medical director is accountable if there are any problems or issues related to that. So again, just emphasizing that it falls upon the medical director, regardless of how decisions are made in the program. And what we have here are the federal criteria in 42 CFR Part 8, and this is what we call the 8-point criteria, meaning the patient has to have meet all of these criteria: absence of recent alcohol or drug use, or abuse rather, regular attendance, and believe me, this involves not only their dosing but their clinical activity. There should be no behavioral problems. There should be absence of any recent criminal activity. Should have a stable home and social relationship, and they need to be in treatment for an acceptable length of time, and there are criteria that we'll review for that. The patient needs to assure that they can safely store their medication, and there are guidelines for that. And the risk and the benefit rather for take-home medication should outweigh the risk of what we call potential diversion. Now, I point out that these are the 8-point criteria that the federal guidelines indicate. Now, in terms of the restrictions of dosing and length of time, these are the federal guidelines. The first 90 days, patient can have 1 dose, and you can see right on up to 90 days and so forth, a 6-day supply. After 1 year of continuous treatment, a minimum of anywhere between 13 and 24 months, you can get a 2-week supply. And what many patients desire to have is their 30-day supply. This means that you have to be in treatment for continuous treatment for a minimum of 2 years before this is possible. Now, the caveat here is these are the federal guidelines. The states for which your program is located have the right, because states have sovereignty, and they can be more restrictive. And in many cases, that is the situation. The state guidelines can be different in terms of the length of time and the amount of take-home medication that a patient can have. For example, here in Pennsylvania, our guidelines are more restrictive, and the maximum supply that a patient can have is a 13-day supply, but they have to be in treatment for a minimum of 3 years, and there needs to be a specific designated reason why. But in other states, as you can see, many patients are eligible to have a 30-day supply of medication after 2 years. So you need to understand what your state regulations are, because the states can be more restrictive. It's important to understand what we mean by exceptions. Exceptions meaning that the patient can be given a take-home medication or bottle, and this is based upon the federal guidelines, when the clinic is closed or if it's a holiday. By closed, in some cases, in some states, in some programs, clinics are not open on Sunday, so they give routinely all patients a take-home bottle. And then on certain holidays, clinics are closed, and the same thing happens. Patient has a medical condition for which, the risk, or the benefit rather, of getting their medication outweighs the risk of diversion. Some patients have medical disorders for which they cannot attend the clinic daily for dosing, or they have great difficulty, what we call medical hardship. So you can apply for an exception to give the patient take-home medication. If there's rehabilitative potential, such as work, you can make, if the patient is in school and it would be prohibitive for the patient to attend the clinic every day, you can apply if there's a severe or emergency situation. You can ask for an exception. Now, this exception has to be according to, again, the federal criteria and the state guidelines, and there's a specific online form and process now. It's very simple to do this. In years past, you would have to call and fax or send it to them, but it's very easy to do right now in terms of getting an exception, and in many cases, the state and the federal approval is coordinated at the same time. It's important to note in terms of alerts and advisory messages, SAMHSA periodically puts on their website dear colleague letters related to issues, so you need to have knowledge of that. In terms of take-home medication monitoring, in some cases, patients obviously often want this as a goal, or it's something that they strive to get as soon as possible. But in many cases, it's not clearly documented. What's the rationale? What we're saying here is that patients shouldn't automatically get take-home medications just because they've been in the program for a certain length of time and their drug screens are negative. They need to have a rationale. What is the reason? Because the likelihood that they have a genuine or bona fide reason or benefit possibly helps to eliminate the risk for diversion. Many patients don't really have a reason, to decrease their supervision of their medication, and I know they don't like that, but they really should have a reason. They should be either going to school or working or have a medical problem such that you can identify the rationale for the take-home. Patients should have, in terms of monitoring, obviously drug testing, and the drug testing should be comprehensive for, common drugs of abuse, including benzodiazepines and marijuana, and alcohol should be included. Something that's new, and I'd encourage all of you to review a recent Dear Colleague letter from SAMHSA that was issued, I believe, in September from Dr. Clark regarding OTPs and prescription monitoring, prescription drug monitoring programs, advising physicians and PAs, nurse practitioners, to use these programs in your state. Now, I realize that not all programs are up to speed with this. There are some states that have excellent PDMP programs whereby you can access this information to see that your patients are getting what prescriptions and from whom, because this information can be very helpful in terms of detecting what we call doctor shopping or polydrug prescribing from many doctors. Sometimes the doctors are not aware that the patient is on methadone and that they're prescribing an opioid pain reliever or a benzodiazepine, and not all patients are forthcoming, so physicians sometimes are not aware, and if you have access to a prescription drug monitoring program, this information is helpful in decision making. Sometimes if you don't have this kind of a program, if your patients are involved in managed care programs, sometimes the managed care program can provide you with information related to pharmacy records because they're paying for the patient's medication and they have access, so you can coordinate and check this information because it helps you make decisions about take-home medications and treatment in general. Also, there should be a review of all prescription medications, and patients, it's good to have a policy to request that the patients actually bring their medications in for the physician in particular and the clinic staff to review and document in the patient's records what the medications are, and further to have consent so that the prescribing physician can be collaborated with if there is an issue or a problem. Patients are required to maintain full attendance for the counseling service based on their level of care. and the length of time in treatment, whether it's once a month or once a week, or whether they're in an outpatient or an outpatient program for groups, they need to have full adherence with counseling. In terms of legal issues related to take-home medications, yes, we have the federal regulations that permit you to give a patient take-home medication, but it does not absolve you of your legal responsibility to act, accordingly. It's good to have what we call diversion control policies, and simple measures such as requiring that the patient return their empty bottles. Now, not all programs do this, but it's somewhat of a good measure to monitor the patient's adherence, and you should have procedures for those who don't return bottles. And in terms of diversion control, for those patients for whom, are not eligible for take-home medication, staying open 7 days a week eliminates the need to give take-home medication to patients who have marginal eligibility or who are really not eligible. Some recommendations in terms of a toolkit or takeaway issues. It's important in terms of a risk management strategy to have what we call callbacks. In other words, if a patient has 5 take-homes, you would call the patient randomly, say maybe on the 3rd, 2nd, or 4th day or whatever, and ask that patient to bring in their take-homes for review and documentation. And in some programs, they actually take one of the bottles and send it off for quantitative analysis to see if the patient has tampered with it or substituted, some kind of a liquid that would appear to be their take-home medication. But it's a good policy to have callbacks and to monitor the take-home. In some cases, it may be helpful to have home safety inspections. I know there are issues of privacy, but sometimes your case management staff, in some programs, they actually go out to the patient's home and get an understanding of how the patient is storing the medication, and if there are children in the home, they can document, what the issues are. Patients are encouraged to keep their medication in what we call a locked container. It's strongly advised, but it is not a total guarantee for safety. I recall of a case of litigation of I believe a grandmother who in one state had take-home privileges and had received a 30-day supply, and unfortunately she had the habit of putting her lockbox under her bed. And although, the clinic documented that they dispensed all her medication in a locked container, unfortunately one day she left the lockbox unlocked under her bed, and one of her grandchildren found the box and consumed the medication and had an overdose. So again, it is advised, but it's not a total guarantee. Again, in this issue in terms of recommendations, screen patients who have children at home, or if they're using other substances and prescription medications, have policies that address when there's an interruption of treatment due to travel, illness, if a patient has a death in the family and wants to attend a funeral, have policies that address that, as well as other emergencies, crises, and hospitalizations. In summary, you need to look very closely at the eligibility criteria, and it needs to be in coordination with your state, because the state can be more restrictive than the federal guidelines. And it's a clinical judgment. There's no guarantee, and you have to make a decision on whether the patient has benefit, and that benefit outweighs the risk of misuse or diversion. The medical director has ultimate responsibility and is the person who's going to be accountable for any actions related to take-home medication. And lastly, you need to monitor, reassess, and on an ongoing basis, if the patient is still eligible, if they're still working, if they still have the medical condition, if they're still benefiting from what we call lack of supervision of their medication, and there needs to be good documentation. Okay, I think that ends our discussion. Are there any questions related to liability concerns related to take-home medication?
I haven't seen any yet, so people, if you do have any questions or anything that you feel is specific to your facility, please either raise your hand or type in the questions box and we'll go over those. Thanks for asking, Dr. Taylor. Okay. I want to wrap up with three what I think are very good case studies, very simple, but they illustrate many of the points that we were discussing in terms of admission and induction, take-home medication, and some of the medical complications you might see in your patients that present what we call liability concerns. Okay, move on. Okay, we have three cases. Case study one rather, is related to the admission process and induction. Case study 2 looks at take-home medication, and these are real cases, and case study 3 deals with the issue of cardiac arrhythmia related to methadone. Okay, let's talk about case number 1. Case number 1 is Mary. Mary is 28 years old, and she presents to the opioid treatment program saying, I need to get clean. I'm tired and run down, and I don't want to be a drug addict for the rest of my life because I know it's going to kill me. I know this scenario sounds familiar to any of you if you're involved actively in an opioid treatment or a substance abuse program. Let's look at her history briefly that she presents. She admitted to the onset of drug abuse as a teenager involving alcohol, marijuana, cocaine, and benzos, very characteristic pattern. However, she admitted to injection drug use involving opiates for the past 5 years. She admitted, though, that she considered oxycodone or OxyContin her drug of choice. She substitutes heroin when that's not available. Upon intake, she denied use of opioid drugs for the past week, but she was having severe withdrawal symptoms, sweats, chills, she was restless, sleep disturbance. She felt tired during the day, and she had loose stools. But notably, she said that in the last 3 days, most of these symptoms had resolved. In terms of her past history of treatment, she had several admissions for what we call inpatient and outpatient detox. She'd been unable to maintain any abstinence for more than 2 to 3 months at a time. And she admitted having a history of depression, but she was not taking her antidepressant medications. She admitted that she would self-medicate her symptoms by increasing her drug use. Now, she was examined here, and her physical findings upon examination, I believe she was seen by the nurse practitioner in this particular program, but nonetheless she was examined. Her vital signs were normal. She had scattered scarring on her arms and hands, and that were consistent with what we call injection drug marks, but there were no fresh puncture wounds that were visible. This particular program did get a urine drug screen that was sent to the lab, and subsequently it was negative for amphetamines, barbiturates, benzodiazepines, cocaine, opiates, methadone, and methadone metabolites. This was the drug screen that was sent. They also did a dipstick, and the results of the dipstick were positive for benzodiazepines. Now, recall the brief history and information that I've presented. Based upon the presenting history, the examination, and laboratory results, Mary was admitted for treatment to this program. And her preliminary treatment program, she was recommended for admission to the opioid maintenance treatment program.
and the physician's statement for documentation of current physiologic dependence upon opioids was completed and signed. Now, if you are involved in an opioid treatment program, this is a requirement. There must be a physician's statement, and sometimes it's documented in different ways, a specific form, right within the history and physical or at the end. But nonetheless, the regulators and auditors look for all patients admitted to an opioid treatment program that the physician has made a statement that the patient has current physiologic dependence upon opioids. And it's completed, it's either a signed statement and it's signed. So Mary's records included that. So let's think here. Are there any red flags with the presenting information? Now, I know we're moving a little rapidly with this, but I would think that you would recognize some red flags. What do we mean by red flags? Well, the first red flag is the diagnosis of opioid dependence, because it's a requirement. You must have this in terms of being admitted to an opioid treatment program. You need to have opioid dependence, and there are diagnostic criteria for that based on the DMS-4 and so forth. There must be documentation of current physiologic dependence upon opioids based on specific criteria, and this should be you should be knowledgeable of this in terms of, you know, signs and symptoms of opioid withdrawal that indicate that the person is currently physiologically dependent. And there should be examination findings that support this, and a urine drug screen that supports this. So now we're thinking about the case of Mary. One of the ways in which some programs document in terms of establishing current physiologic dependence is this scale called the COWS, or Clinical Opiate Withdrawal Scale. Now, this is just one way of doing it. Doesn't mean you have to use this, but it's a very convenient, common method that documents the patient's vital signs in terms of the pulse, whether there was diaphoresis or sweating, and you note there's specific criteria. You indicate the date and time that the patient last used. In the case of Mary's history, it would be a week ago, okay? And then you look for evidence of sweating within the past half hour, and you grade it in terms of this scale, 1 through 4. Same thing with restlessness, observation during the assessment, pupil size, and so forth. In other words, you come up with a number, a diagnostic number that puts you in the range of whether the patient is experiencing mild, moderate, or moderately severe or severe opiate withdrawal. And you can see the numbers as they add up. So if you had a patient that was very in acute withdrawal, very sick, the patient would have beads of sweat on their brow. They would be very restless, fidgeting, restless leg syndrome, unable to sit still. Their pupils would be obviously dilated. You can measure this in millimeters. They would complain of joint pain, and you'd see the runny nose or rhinorrhea. And sometimes this is manifested by the patient constantly doing this during the intake or the assessment. Sometimes patients have such severe stomach cramps or nausea, vomiting, that they have to excuse themselves during the process and so forth. Yawning is a very helpful observation. If a patient yawns at least once or twice, that's significant in terms of indicating that the patient is in withdrawal and has evidence of physiologic dependence, anxiety, and obviously what we call goose flesh or piloerection. You feel the goosebumps and you palpate the backs of their arms. So again, you come up with a total score and you indicate that, and it gives you documentation of what was observed at the time that this patient was admitted. Now, again, going back to the case of Mary, if you recall, she had less than 5, if any. So she would be, at best, very mild to absolutely having no indication. Nonetheless, she was admitted and she was started on methadone. Now, in this particular program, they have what we call standing orders. So patients, and note the day of the week, she was admitted towards the end of the week on a Thursday. And on day 1, the physician wrote the order for 30 milligrams. Day 2, he increased it by 10 to 40. Day 3, she was increased to 50. And on day 4, the clinic was closed. And as you recall, this particular program was not open on Sundays, and they had an exception to give all patients take-home medication. So she had her dose increased to 60, which was already ordered, so she got 60. And then the next day, that Monday, she came back, and the physician had written for a dose increase of only 5. She got 65. Let's look at this in a little detail here. So, again, she was started at 30, and the standing order was from 5 to 10 milligrams. That's how their orders were written. And then she received 40 on day 2. Now, according to the dispensing nurse, Mary reported withdrawal symptoms, and so the nurse said, well, you're going to get your dose increased today to 50, so she gave her 50, and this was Saturday, and she was instructed that she had her take-home dose of 60 for Sunday. Okay, so she got on day 4. Now, she came back on Monday, after having her 60 on her take-home. She reported not having any withdrawal symptoms to the nurse, and she did not want to go up any higher because she didn't want to be like those other patients in the program who are on very high doses. And also, it's noted here that Mary was somewhat unsteady on her feet, but because there was a standing order, the nurse told Mary not to worry about, her dose being high. She needs to be on an adequate dose to stabilize her and stop her from using, and don't worry about other patients in the clinic. And she encouraged her to, take her dose as it was ordered, and gave her the 65 milligrams. Now, on day 6, which was Tuesday, Mary was a no-show. So the clinic counselor did an outreach call, and he called the patient's home and found out that Mary had passed away the day before. At autopsy, which was performed 48 hours after her death, the report indicated the circumstantial cause of death was due to pulmonary edema, which is classic for opioid intoxication death, secondary to methadone intoxication. The forensic toxicology report reported that she had high levels of methadone and methadone metabolites. There were no other substance or drugs, benzodiazepines, present. So the lesson learned here is lack of recognition of what we call steady state, the pharmacokinetics and pharmacology of methadone. What you see depicted here, and I don't know if my pointer is active, is a graph that shows the cumulative effect of methadone as it builds up, achieving steady state over a 7 to 8 day period. And this represents the peak on day 1, the trough, the peak, the trough, the peak. And as you can see, there's a steady rise till about day 4 to 5, and then it levels off. And what this reflects is that there is a buildup of methadone, and that the half-life is about 24 to 36 hours. And this is with a constant dose. This isn't with a dose increase. In other words, if you got methadone 30 on day 1, on day 2, 3, 4, this is the accumulative or buildup effect. And it's very helpful to show patients that this is why you can't increase their dose too rapidly, because their body has to adjust or get used to the buildup of the methadone. You see that peak levels increase daily over a 5 to 6 day period, and this is without no dose increase. I'm going to show you what we call is the methadone dose equivalent effect for Mary's case, and you can see the point. I think it drives home the message. So day 1 she got 30, so she had an equivalent effect of 30. However, on day 2 she got 40, a 10 milligram increase, which reflects 50% of this combined dose in her system. So she had the effect as if she got 55 milligrams by increasing it by 10. By increasing it another 10, she had a dose equivalent effect of almost 76 milligrams. By increasing it to 60, we see the progressive increase to 98.7 dose equivalent effect. And then the final dose that she got, you can see it increased by 5 milligrams, but the accumulative effect here over that 5-day period was as if she had 143 milligrams of methadone. And this is what was responsible for her demise. You can see that the equivalent effect due to the accumulation of the tissue buildup was if she got 144 milligrams of methadone, and her tolerance, as you can see, was limited at best. That is the issue related to the induction, but I want to review the basic problem of the tour documentation, because this case has been presented many times, and some have the opinion that they would have not admitted her and given her methadone, which can be argued, and I think effectively, that she didn't meet the criteria based on the information that was presented. And this is a real case. This patient was admitted to methadone treatment and did not have documentation that she had current physiologic dependence. So quite obviously, you can see the potential for overdose. So it's important from a risk management standpoint to document very clearly that the patient was currently physiologically dependent based on some established statement or instrument that points out recognized criteria. So in terms of risk management related to induction, you need to have a thorough and comprehensive assessment, and you need to carefully document the diagnosis of opioid dependence and that there's evidence of current physiologic dependence. The other salient issue in this case was avoiding standing orders. And there, Dr. Clark issued a Dear Colleague letter back in January of 2008 advising programs about the need to have individualized orders and advice to avoid the use of standing protocols, which, as you can see, can cause serious problems. It's important to observe and document very carefully, and the mantra that we preach is that you start low. The guidelines permit that you can start at a dose of 30 milligrams, but not every patient requires that. Many cases, the patient can do very well on 10 or 15 or maybe 20 milligrams, and that when you do increase, you go slow. You do not ignore the pharmacology or pharmacokinetics that we just discussed, and you need to allow between 5 to maybe 7 days before a patient has a dose increase, because it will accumulate. You need to respond to patient complaints and the change in their status. In this case, Mary pointed out to the dispensing nurse that she wasn't having withdrawal, which was somewhat unusual, and that she was noted to be unsteady on her feet. And this is the kind of red flag that gets programs in trouble. It's documented that she was staggering or appeared to be overdosed or potentially over-medicated, yet she was medicated and given a standing order. So you need to respond to complaints and issues and have policies that assure that patients can be adequately addressed or assessed. Let's quickly move on to the take-home case. This is Stan.
Excuse me.
I'm sorry.
Dr. Taylor, I do have a question
Okay.
that was raised on this last one, and I thought you'd want to go back to that since it was so close.
Okay.
The screen you have where it showed the accumulation over the, the question is, can you explain the math for day 5? 98 divided by 2 is 49, plus the 65 would yield 114, not 143.75.
Oh, okay. Well, maybe they, again, these slides have been modified, and I didn't check the math. This has been taken from, the original case, and if that is correct, I will correct that. But again, I believe this was taken from the original case, which has been somewhat modified, and I just used these slides. But you're right, it might be, but nonetheless, it's not 65 milligrams. You said 114?
Well, they're saying that that 98 divided by 2 is 49. So that's and then plus the 65 from the last
Right.
would yield
Right.
115, not 143.
Yeah. Okay. Well, we'll make that correction, but nonetheless, I think the point is the math may be incorrect, but the point is that the effect is higher than what the dose is. That's the point. Because even here at 30 and going to 40, you have a dose equivalent effect of 55. Is that understood?
Yes, thanks. I just
Okay. That's the, yeah, okay. We'll make the correction on the math, and like I said, I'll go back over and review because this is a modification of the original training that we did, and I didn't review the math. I just went on what was presented here.
Yeah, no problem. Thank you very much.
Okay. Any other questions on, will we go back to Stan? No?
No, not right now.
Okay. Okay, let's move quickly to Stan. He had a history of snorting of heroin and oxycodone, and he was admitted to the program, and he was titrated and stabilized accordingly on a dose of 120 milligrams after some time in treatment. He didn't meet the criteria for take-homes for work, but they requested take-homes, and they presented the exception to the state because he had a job and the hours of the clinic were not in conjunction with, were in conflict rather with his work hours. In other words, the clinic, I believe, didn't open up until 7, and he had to be at work at 6. So his drug screens at the time were negative, so they applied and got an exception, and he was given 5 take-homes, per week so that he could work. However, there were complications. By the 3rd month, it was noted that Stan wasn't attending his counseling, and that his urine drug screen on that 3rd month was positive for oxycodone, and it was reported that he had a party or went to a party, and that one of the patients or people at the party died after they found and took his methadone. There was a case, a lawsuit brought against the clinic. Reportedly, he said that, yes, he had his take-home stored, but somebody at the party found his take-home medication, and obviously this person who died was the person. The clinic, in this particular case, was successful against this lawsuit because they had excellent policies documenting everything. They took action when they noticed that, his he wasn't coming for counseling. They removed his take-homes. When his drug screen was positive, they removed his take-home medication. They had excellent policies and procedures in place to prevent what we call foreseeable action. But the patient was liable here because he did not store his medication out of the reach of others and was responsible for that. The clinic was not responsible or liable for the patient not taking sure that his medication was not out of the reach of others. So again, here's an example where the exception was granted by the state and the feds, and it was well documented. He had a valid reason, that he had good policies and procedures in place in terms of the patient, and they weren't negligent. They took action when his counseling was not adherent and when his drug screen was positive. So the implications here are that protect yourself by having good policies. And as I pointed out, they had policies for take-home review, callbacks, drug screens, and so forth. In terms of if you don't have these situations whereby you can address patient needs, I have seen programs change their hours to accommodate patients. Now, if the clinic had been open earlier, Stan wouldn't have required to have take-home medications. And in certain parts of the country, you know, programs open up at 5 in the morning for patients who have to be at work at 6. So this is a risk reduction type measure that you can consider to avoid having to give patients take-homes that are marginal in a sense. And then also, obviously, opening 7 days a week is another measure that can lower your risk involving take-home medications. And the clinic's responsibility to third parties, yes, you're responsible to a certain degree to protect the public and to document that you took foreseeable and reasonable action to have policies and procedures that are designed to address this. Like, you can't be responsible for all actions of the patient, but you know, there's a certain area in which the clinic has a certain responsibility. The last case is a case of cardiac arrhythmia, something we call specifically Trusandra de Point, which is a specific cardiac arrhythmia. It's a ventricular arrhythmia, and I realize that many of our attendees are not physicians or medical staff. We're talking about a severe, life-threatening, abnormal heart rhythm that can be fatal. Glenn is a 36-year-old male. He was on a dose of methadone around 300 milligrams, and he transferred to another program. Now, his history was negative for any cardiac problems, and he had no other medications that were indicated. However, on exam, he had what we call a marfanoid habitus, which is a specific syndrome called Marfan syndrome. You know, he had all the physical characteristics of this particular disorder. I won't go into detail, but he had that kind of body habitus. And the only other abnormality was that he had a history and had bronchitis that was noted. And the remainder of the exam was normal. In terms of his family history, his father had a history of heroin addiction, reportedly, and had previous treatment with methadone, and he stated that his father required 500 milligrams of methadone, and it was noted. Now, he was maintained in this program, and they increased his methadone, you know, somewhere around 20 to 25 milligrams over an interval period of time. And by November, his dose was increased to 435 milligrams, but he only felt about 10% better. Subsequently, he had further increases up to about 600. These were, you know, slow, progressive increases, not rapid. And he began to feel a little better, around 30%, but at trough, remember when the methadone level is low, that's what trough is, just before dosing, he was examined and noted to have what we call dilated pupils. In other words, he was felt to be in withdrawal, and, you know, this is evidence of that. So the physician continued to increase his methadone dose, and he was up to about 660 milligrams, feeling about 50% better. But one day in March, they got a call from the emergency room that the patient had what we call this fatal, potentially fatal arrhythmia and had a grand mal seizure. So he continued to have these episodes of ventricular tachycardia, and what they did, they admitted him to the ICU, and to move this along, they continued his methadone dose, but they dropped it to 400 milligrams total, as you can, giving him 100 milligrams every 6 hours, and they implanted a ICD and temporary pacemaker. However, the patient at this dose continued to have 400 milligrams, continued to have withdrawal symptoms, and ongoing problem of the ICD firing. So what they ultimately did, at 420 milligrams with complaints, they gradually increased his dose to 600 milligrams to the point where he was at 600 milligrams, and as long as he had the, you know, temporary pacemaker and the ICD, he was monitored and was, much better. So this is just, Trusandra points is not common, and there's a lot of controversy today about this issue of cardiac effects of methadone that is dose-related. In most cases, you see serious problems of cardiac arrhythmia, potentially at doses of 200 and higher. This issue of the QT interval, again, I'm not trying to bore the people who are not physicians, but it's a specific segment of the electrocardiogram that can be prolonged, and there can be other drugs and many causes related to that. The majority of prolongation of QTC does not result in what we call the Trusandra points, arrhythmia, but it's a concern right now, and it's controversy in terms of program involvement. CSAT did convene an expert panel in 2008 to provide recommendations for QTC interval screening in methadone programs, and the final report is pending, and I believe it will be published in terms of specific guidelines that address the issue of evaluation at admission and during induction, and what we call in serial follow-up, and gives specific guidelines or recommendations rather than how programs should approach this. Nonetheless, if you want something to refer to, ATOD does have, I think, some good recommendations or guidelines at present that you can use on their website, and it emphasizes a thorough examination of the patient's history, family history, and physical exam. And if your patient has any heart-related problems or symptoms or fainting spells, palpitations, unexplained seizures, or family history of any of the above, then, and also if they're on any medications, then there's a very helpful website that you can check to see which medications, and believe me, there are a host of medications that can cause prolongation of the QTC interval that could potentially lead to this arrhythmia, and you need to consider that. But if you see any of these risk factors, it's a good idea to either order an EKG or do one within your program. Some programs have invested in a machine and taken it upon themselves as a risk management strategy to identify these patients early so that they can take what we call preeminent action, either follow up with a cardiologist or their primary physician to address this. So as I said, the SAMHSA CSAT recommendations will be coming out, I believe, sometime early next year prior to the, or at the ATOD conference. But nonetheless, the ATOD has good recommendations that you can follow on their website. Okay, I don't have, are there any questions related to cardiac effects?
I do have a question here. It looks like there's two.
Yeah.
One is, can you please define more of current physiological dependence? Does that mean having withdrawals using, does that mean having withdrawals with the use of opioids?
Current physiologic dependence, yes, means having withdrawal, but also there needs to be a recorded history of the patient's period of use, because it's required in there that you need to state that the patient has been, or you have evidence or information that the patient has been physiologic dependent for a year. And, you know, none of this was, or in the case of Mary, it was poorly documented. So you have an obligation to explore this. I think the take-home message here is that you shouldn't be in a rush to admit patients unless you feel confident that they are truly physiologically dependent based on their physical presentation, their history, and that you have some means of confirming that.
Okay.
You know, consensus was that, you know, possibly Mary should have had further evaluation and confirmation of her history, and certainly with her presentation, it was most considered dangerous to give a dose of methadone of 30 milligrams to a patient. such as her.
Okay. Here's from the same person. In 42 CFR somewhere, she's not sure where, but as an eligibility of admission, there is an area that current physiological there's an area that current physiological dependence is excused if the individual was released from the criminal justice system. Does it mean that OTP can admit the individual who has not used an opioid while he or she was incarcerated and released but not using any opioid?
Yes, that is the exception, but again, that needs to be very carefully done. And yes, I know what they're talking about. There are specific criteria within the, if someone has been incarcerated and has been released from prison but is fearful of relapse and wants to re-engage in opioid maintenance treatment involving methadone, you can readmit that patient because they previously had physiologic dependence, but the titration of methadone needs to be done very carefully.
Okay, and those were the questions for that section. Thanks.
Yeah, right. Okay. Are there any other issues?
Not that they have let me know about yet.
Okay.
I think we're ready to go again. Thank you.
Okay.
Okay, I think we might have lost Dr. Taylor for just a moment. So just take like a 3 or 4 minute break and we'll get her back and on to this last section. Thanks.
Sure, Chris. And also I saw one question about the intended audience. And it does seem that the most people likely to be in this audience are OTP administrators, but that's not always been the case. We've had clinical staff, you know, who have administrative roles attend the training in the past as well. It is not just defined to OTP administrators. It can be to the docs who are the medical directors or the nurse managers, etc. Yeah, this is Holly Hagel from the Northeast ATTC. If you all could just hold on another 2 or 3 minutes, we are still continuing. We're just getting Dr. Taylor back logged into the system. Again, Chris is trying to get Dr. Taylor back into the system, so please continue on with the break.
We are still trying to get Dr. Taylor back on the line, so please hold on for just a little bit longer. Thank you.
This is Holly again. We have tried to call Dr. Taylor. We're not exactly sure what happened with the connection. So we are working on it. We're going to give it another few minutes and see if we can get her back into the system. She did, to my awareness, cover up to Module 6, so that is the 3 modules that she intended to, but we're sort of doubtful that she would just leave the webinar so abruptly, so that's why we're double checking with her. If anybody has any questions or comments at this time, we can go ahead and open your audio while Chris is still trying to reach Dr. Taylor. And as I said, we'll give it another few more minutes, otherwise we'll continue on and talk to you all during part 3 of the webinar session. Let me check the question line. And if you would like to, I can unmute you. And Chris, when you're back in, if you made your other attempt to contact Dr. Taylor, we'll just leave it at that if you weren't successful. If you didn't get this as we were logging into the webinar, when we started, I was explaining that at the end of the 3rd webinar, we will be making some modifications to the trainer's manual, and then we will be disseminating that manual both digitally and print copies and binders to you all who participated in this webinar series and right after the new year. And then into the following that dissemination of the trainer's manual, we'll hold a brief 1-hour webinar just to talk about instructional delivery of the curriculum, just to support you all as trainers who are thinking about going out there and actually training opiate treatment providers. Again, the audience is tailored to administrators and clinical staff. Just come in, Chris. You can't reach her? No. Okay, then I'm telling the group that we're going to dismiss them. I just was, you can stay if you'd like. But I was just reviewing that it was for administrative and for clinical staff, because there obviously is a lot of clinical material as well. But we've had a mixed audience. Again, we apologize. We're not really sure what happened with Dr. Taylor. Maybe her internet went out. Oops, let me see if there's another comment or question that came in. Okay, see, this is a very detailed question that I'm not able to answer, but I can pass this question on. It's about cannabis intoxication, and we can get further clarification on that with Dr. Taylor herself through email. And as we've been communicating to all of you through email about this next segment of the webinar, we will answer questions that way as well. Okay, well, I think I'm going to go ahead and dismiss you all. Thank you again for your time and attention. We will be in email communication, and I'll look for the email that is for the link for the 3rd webinar next week, and we will finish it up from there. Again, sorry for this inconvenience. We're not quite sure what happened. Thanks, and have a great day.